Okay, so this is now, it's going to be a lot of information in a very short time. So skip or be very brief on some parts. So you can ask me afterwards if you think I'm too quick. So this is the technique, and I'm going to try to show you that you can use that to study and to treat the human brain. So we are actually, I'm coming from the opposite direction. But you heard the name, transcranial magnetic stimulation, in the previous speech. So a little short history. This relationship between electricity and magnetism was described by Michael Faraday in his law. This was published like that. Next, you find an Italian, Giovanni Aldini, who was a nephew of Volta, and that is why he had the possibility to get something, electrical stimulator. And he used that to stimulate, it was a peculiar situation because he actually stimulated the heads of newly beheaded citizens. And these were public shows, which of course attracted a lot of attraction. And it was also written about in the papers, and it's believed that some of this information was spread to the north, to Switzerland, where Mary Wollstonecraft Shelley was spending time together with her husband, Percy Shelley, and Lord Byron. And they had a competition. They tried to write ghost stories that would make an impression on each other. And the only one that survived is hers. So she heard about these activities in Italy, and she thought about another old story, that one of Prometheus, the guy who brought fire from the gods to the humans, and he was punished by Zeus by having his liver picked out on a daily basis until eternity. So then she created this, as most of us know as the monster, which is actually called Frankenstein, or the modern Prometheus. And it's a book, not much of a ghost story actually, it's more a story of, an ethical story of how the responsibility of the scientists, what you are doing when you're trying to change things. And now, as you may have seen, there is another, even more modern Prometheus. This one, which is now actually playing in the cinemas, it's the Ridley Scott prequel to the Aliens stories. So it's like, it's a bit like this, that you think it's already happened already. And there should be a little sound bite there, but it doesn't work. So okay, so I'll go on with the next stimulator. It's Robert Spatalo. He was an American, and he's believed to be the first to actually stimulate the human brain. It's a rather sad story, which I can give you afterwards if you'd like to hear it. Then we came back to Germany. So Theodor Krause was the one who actually made this systematically for the first time. And he produced these kinds of very elegant systematic maps of where different stimulations could produce different effects. And he had a student called Ottfried Förster who learned the technique, and then he, as you see here, he got a letter. And this letter was again from the other side of the Atlantic. It was Wilder Penfield who wanted to come to learn the technique, and so he did. And he was a rather severe person, it's been said, but he also had his good days. What they did in Montreal, which was the foundation for the Montreal Neurological Institute, which is still there, very active, was that they stimulated brains of people during operations for mainly severe epilepsy. And these people were awake, so they can report what kind of sensation was produced by the stimulations, and they can, of course, also observe motor activity from that stimulation. And then it ended up with this, at least for medical people, very well-known homunculi, which is sort of a distorted image of the sensory and motor activities along the cortex just before and after the so-called central sulcus on the side of the brain. And then very short about the stimulation technique as such. It was described in 1985 for the first time by an English engineer, Anthony Barker, who then in Lancet described how you can stimulate the brain painlessly, because the electricity is very painful. But you can do this painlessly in humans, blindly in his case. And then this is Risto Ilmoniemi, who is one of the people who actually now produced what we use now, the so-called navigated transcranial magnetic stimulation, where you can actually see what you are doing. He's working in Helsinki, and that work was the foundation for what was leading up to this. Is a machinery where you have a stimulator, you have a computer that controls everything, and you have reflectors on these glasses that the patient or subject is carrying, and on the stimulator, which is then detected by infrared light, like that. So you can see online where you're stimulating, what kind of responses you're producing in different muscles from where you are recording. So this is what the way it works. So you reload the patient-specific MRI into the machinery, and you connect the person to the image with that tool there, and you make a stimulation, and you get your results, and this is the kind of diagnosis. You can detect areas from where different stimulations produce different results. And much of that work has actually been carried out here at Charité, the Department of Neurosurgery, and Thomas Pitt, is one of the main investigators there. Here he is standing, stimulating. So this is an example for what they have been doing. They have been used it mainly in people with brain tumors that need to be operated. And this is stimulation map. All the stimulation points are white here. And then if you take the ones that produce a response in a hand or a foot muscle, they were there. And this is a tumor over here. And then they compare that to the standard technique at that time, which is intraoperative direct stimulation. And then if you augment it a little, so you see that they fit very well together. So the conclusion from this and other studies was that these techniques, they agree very well. And in this case, this tumor could be resected without any more problems for the patients. So now they just released a new version of this machinery, and this is just, they managed to get it all together into one unit. So it's very much user-friendly. So, what are the principles? Well, there is a very short electric current going through the coil, producing a magnetic field perpendicular to that plane, and then inducing a new electrical field in the tissue, which is then activating the cells. The magnetic field travels very rather like a decimeter or something, whereas the electric field is much less penetrating, a few centimeters usually. So from this coil you produce different kinds of fields. If you have a circular coil, it looks like that. If you have a figure of 8 coil, it's more focused. And then you activate mainly the axons of the nerve cells. And then you can calculate what kind of fields are produced in the brain, and you can look at different areas of the cortex, different cells in different places, and you can try to figure out how to activate different cells in different ways. And we try to do that in a study where we use this machinery's capacity. This is one of the results. So this is the way we stimulated, which was, we believe, more precise compared to the standard method, which gives a much larger activation area. But the even more interesting result was that if you stimulate, in this case, 8 different people, 4 different muscles in each, 3 different stimulation intensities. So you see there is a very large variation, both within and between individuals. So one of the main conclusions were that people are different, should be treated like that. So we can use this for different studies. This is a physiological study, normal brain functioning. As I told you before, there is this idea of motor activity before and sensory activity posterior, behind the central sulcus. So now we try to do something else. We try to stimulate the sensory area to see if if you can get something like a moving feeling if you excuse the pump. So the setup is that you record from 3 antagonist muscle pairs, and this is the way the stimulation goes on. You can see on the screen exactly where you're stimulating, what kind of responses you're getting. And the results were, to summarize, that we were able to produce responses consequently from this so-called sensory area, which has not been done before. So this is the kind of responses. So this is the central sulcus, this is the so-called sensory area, and all these colored dots, these are areas where motor responses were produced. Now you can look at pathophysiology, how the brain has changed, for example, neuroplasticity, how the brain can adapt to different things. And this is rather, this is of course old news, you know, about this Pantare and this never stepping into the same river twice. This was a boy who, at the second day of life, had a large left brain damage due to ischemia. So he has hemiparesis and he has a mild mental retardation. His biggest problem is that he has a terrible epilepsy, which is actually producing loss of function. So the question is it possible to operate to reduce this problem? So they asked us, from where is his right hemiplegic hand controlled? So we tried to look at that, and we stimulated the damaged left side. We got no responses in his right hand. We got some responses from his right forearm, and we got a reasonable amount from the right leg. Looking at the undamaged hemisphere, we got, as expected, responses from his left hand and forearm, but also from his right hand and his right forearm, and actually in some areas, we could activate both hands simultaneously. So the conclusions were from this that the motor control for his hand, his right hemiplegic hand, it was completely transferred to the right hemisphere. His forearm was controlled partially from the left and partially from the right hemisphere, and the leg area was remained in its original place. So this is just an example of how the brain can adapt to even severe damages. So you can use this also for diagnostic purposes, except for the ones I just mentioned. This is a rather new, this spring it was published, how you can try to localize language function, also before operations, where you don't want to change or destroy the language of the patient. And in this case, they combine this advanced navigation technique with a video system where you can produce images, so the subject has to name them. And at the same time, you give very short repetitive stimulation over the, in this case, the left hemisphere if you're right-handed, and then they produce this kind of stimulation maps, and then they were able to say that in these points the production of language was disturbed. So when this is developed, you can also use this to help reduce the risks of operations. So can this be done in children? Yeah. This is a girl who was 3 years in the beginning of this story. There was no problem in the first years. When she was approaching 8 months, she had this rather strange symptoms. She kept falling, blinking, she got unsteady, and whatever they looked at, except for the EEG, it was normal. So she was diagnosed as having focal epilepsy, and she was put on carbamazepine, which worked nicely first. But then after half a year or so, seizures reappeared, and she actually started to lose functions. So epilepsy is a dynamic problem. So they changed treatment, didn't work. They added some others, didn't work. So first when high doses of steroids were used, she got seizure-free. her EEG normalized when she was awake, but during sleep she still had this rather disastrous pattern, continuous like wave pattern. So high doses of steroids, it's actually a rather risky treatment with these kinds of side effects. So they tried to reduce it, but then seizures reappeared, and she also developed these kind of symptoms again. So the question was, is it possible to operate this? Anyway, this is the mapping that we came up with. So all the colored dots or areas where we could produce responses in our contralateral muscles. And this is where the EEG and other investigations pointed to the source of the epilepsy. So actually, after long hesitance, surgery was performed, and it looked like a gliotic area, and this was confirmed in the pathologic anatomic diagnosis. So it's just a sort of a scar, it's no tumor. And 6 months later, she has no seizures, she has a normal EEG, remarkably recovery of speech and hand motor function, and now the steroids are reduced. So this looks good. So what else can you do? You can inform the neurosurgeons in other ways as well. You can use a technique called tractography. This is a case of a woman who presented with a generalized seizure, and MRI showed a large tumor on the left side. And then we made our recording stimulations. So this is a tumor here, and these are the areas from where we could produce hand and forearm responses. And this is the leg responses. So this looks a bit more scary because it's actually in the tumor area. But then you can use these spots from where you can activate the muscles to produce with the technique I mentioned, tractography. You can calculate where the tracts, the signal paths are going down into the brain. So these are the white areas here from different angles. So you can follow these down, even down to the brainstem like that. This is a sort of graphic picture of the tumor from front and side view. So this also increases the possibility of making these operations without harming the patient. So then we come to the therapy, and you just heard about this actually. So this was a couple of weeks ago in one of the Swedish newspapers. There was this outcry from the public. Why can't we have TMS against depression? It's not, in Sweden it's not used, almost? Oh, sorry. As I understand in Holland and in the United States, it's not in Sweden used for this. But we have other things that we're trying to do. So basically, what's the problem in these situations? There is a unifying theory called that says that there is a so-called dysrhythmia. So the way the brain is working has been changed. And this is a rather complex theory, which I can't go into, but it ends up with a so-called edge effect. So you have this sort of a standing wave, uncontrolled activity that can produce different kinds of symptoms. So how can we get to that with this method through repetitive stimulation? And this has also been shown that this kind of stimulation will change the way the neural cells are working in a controlled fashion. So where has this been used? Well, one of the situation is after a stroke damage. So it has been shown before that after a stroke, instead of the balance between the hemispheres, you don't only lose the activity in the stroked hemisphere, you actually get a stone on that burden because the undamaged hemisphere is actually inhibiting this damaged one. So what you can try to do is then to activate the damaged and deactivate the undamaged. Try to help these people. So this is an ongoing study. As I just give you an example. What happens to excitability? How easy is it to activate these motor areas? So this is the undamaged side. Now it's Swedish here. We looked upon it before and just after, and then 2 months after a treatment. So you can see that the red after, you actually deactivate the undamaged state as intended, and at least 2 months after the treatment, there is an increase in the activity level, the excitability level on the damaged side. So this is just one patient, so it's very preliminary, but it may be actually working. Another area is the so-called central pain. Usually after some sort of central damage, the classical one is thalamic damage after a stroke. And it has been shown using this technique that if you stimulate somatotopically, as I say, you look at the areas that you activate the right areas in relation to where the pain is in the patient, you can actually get to this. And we try to do that also, treating a patient 3 days in a week, and the green is the pain level, which goes down during this week, and his social activity level goes up, and when after this stimulation, when they are stopped, these changes are reversed. And this is known that these effects are usually rather short-lived. But it seems this is also a way to deal with that problem. Another way, sort of the most extreme situation of this dysrhythmia, is epilepsy. This is a case of a woman who ended up in a so-called partial status epilepticus, that is epilepsy that doesn't stop, whatever you do. And she was in intensive care for 50 days, and the epilepsy level is the red and the black dots and stripes here. The reaction level is the green one, and she was treated with all kinds of different anti-epileptic drugs, and nothing worked. So then after 4 weeks, I put the question, could you try this technique? And then the neurologist said, maybe. So another week went by, and I asked again, so could we try this? Maybe that's dangerous. At the same time, they noted that they don't really have no other options left. And if she would have a cardiovascular catastrophe, nothing would be done. So another week went by, so I put the same question, and then actually I got this reply, so try that. So we performed the stimulations over 8 days, and you see the epilepsy level went down, her reactivity level went up, and then she spent a few more days there, whereafter she went to an ordinary ward, and now she's slowly but surely rehabilitating. And the cost for this intensive care is something like 200,000 euros. And some people claim that you shouldn't mix healthcare with economy, but in reality, of course, there is a relation. So if the treatment had been started here or there, these resources could have been used for something else, and she would have fared better. And now, something different. Yeah, this is something that we tend to forget in medicine. We make these kinds of comparisons between a new treatment and then we compare that to a placebo situation. And then you find this kind of average and some spread from that, and you say, so the treatment didn't help. The thing is that behind those figures could be this. So for some individuals, this treatment could actually be of great value. So I think that we should try to get back more to this. And of course, this is something that is not always easy to get across. So I think I skipped the last one because there is no sound. Okay, so then I'm finished.